We'll just give it a couple minutes and let more people trickle in, and then we'll go ahead and get started. So probably like at 12:01, 12:02. Okay, Dr. Gonzalez, we can start.
Hello, welcome again to our Latino Health Forum, the 29th Latino Health Forum. As we explained yesterday, is going to be electronic this year again, like happens the year before, because the terrible pandemic that we're still suffering. So next week, Monday, we won't have a speaker, but the rest of the week we will have. And we will repeat the lecture in the KBBF, this public radio, bilingual radio station in town. Today, I'm Enrique Gonzalez Mendez. I'm a family doctor. I'm working for SOTER and the residency program. And I've been so lucky to be the chair for so many years to this amazing forum. Today we are very lucky to have a specialist in internal medicine and infectious disease, Dr. Green, who is so kind and use some of the time to help us. But for you to know more about him, let me introduce Andrea Garcia, that is someone that I know for many years, always working in the community. Last time I saw her in person, she was in the middle of Lake County vaccinating Latino farm workers. So welcome, please, Andrea.
Thank you, Dr. Gonzalez. Welcome, everyone. My name is Andrea Garcia. I work for Sutter Health as a community health coordinator, and I'm also a board member of the Latino Health Forum. I'd like to thank our sponsors for making this event free of charge. This is our 29th annual forum, and we definitely hope to be able to return to an in-person event next year. But I'm really excited today to be able to open up this workshop October 8th about understanding the COVID-19 variants and vaccine safety. Our speaker, Dr. Green, is an infectious disease specialist at Sutter Medical Group of the Redwoods with a broad expertise in hospital and outpatient infectious diseases, including international travel medicine. He is double board certified in infectious diseases and internal medicine and a recognized fellow of the Infectious Diseases Society of America. He is the medical director of quality at Sutter Medical Group of the Redwoods and serves as the medical director of infection control for our Sutter Santa Rosa Regional Hospital in Sonoma County. Dr. Green earned his medical degree from Georgetown University School of Medicine in Washington, D.C., and completed his internal medicine residency and training at the Medical Center of Delaware in Wilmington, Delaware, and in St. Joseph's Hospital in Phoenix, Arizona. He completed his infectious disease fellowship at the University of California School of Medicine in Los Angeles. Dr. Green is an active member of the infectious disease and medical community, often collaborating on timely research subjects. For nearly 3 decades, Dr. Green has contributed papers to numerous peer-reviewed medical journals on topics including antibiotics, COVID-19, HIV, Lyme disease, metagenomics, and chronic meningitis and orthovirus, COVID-19 illness on cruise ships, and remdesivir treatment on COVID-19. Dr. Green was recognized as a Sonoma County Public Health Champion in 2003, and he has been a resident of Sonoma County since 2001. So with that, I'd like to welcome Dr. Green and let him get his presentation started.
Hello, everyone. Thank you very much. It's nice to be here today, and thank you for inviting me to give this talk. I'm going to go ahead and kind of begin to share my screen. Let's see. So thanks very much. I really appreciate being here. I thought I'd let you know a little bit about me. Yeah, I am from Phoenix. I actually grew up in Phoenix, Arizona. You know, my dad was, we have a multicultural family. My dad was Irish and British. In fact, his mother immigrated from England when she was 6. My mom, however, is Mexican, and my mom's mother immigrated from northern Mexico when she was 6. So it's very interesting to have both that side of the family. I must say, I think the Latino side of our family is clearly the more fun side of the family. Certainly, I can make really good enchiladas, but I can't get close to my mom's tamales. They're just really out of this world. And again, you know a little bit about my training, graduated medical school. It's interesting to be on the East Coast as well as on the West Coast for your training, because I think that really broadens our medical perspective. Today's outline, we're going to cover what's going on with COVID-19 right now in the US, and then we're going to start talking about the vaccines. I want to focus on, you know, what vaccines are we using in the United States? Because what vaccines we're using in the United States is different from what's being used in the world. How effective are the vaccines? How safe are the vaccines? I think a lot of people want to know that. And then a little bit about the boosters at the end. As we talk about this, I also want to let you know I'm going to be giving you information and I'm going to give you science. I'm not just going to give you opinions. I want you to have data. I want this to be somewhat evidence-based. I apologize if there's a lot of information. I apologize if there's too much science. I don't want to lose you, but I want you to know that we're not just kind of shooting from the hip here. We're talking about something that's really important and is rooted in science as we move forward and apply that in population management of this historic pandemic. This is kind of what's going on right now in the US. These are new reported cases, and I'm going to kind of roll through this with you a little bit. You know, everyone says that, okay, here was the first wave, and then here was the second wave. That's actually not really true. The first bump we had saw in New York, and the second bump was a different part of the population seeing their first wave in another geography. So these first and second surges were really the same surge in different locations. And then in the wintertime, we didn't have vaccine yet. And in the wintertime, we had this huge winter surge. So things got cold, people went indoors, we were trying to wear masks, we were trying to loosen the restrictions, but at the holidays, everyone was mixing with families. And at this time, I'll tell you, I call this, with this dotted line, the pre-vaccine era. In the pre-vaccine era, what I would see was cases come to the hospital. They would usually often be in ethnic families where there were multi-generational families living under one roof. Might be Italian, might be Asian. A lot of it in our Canada was Latino. And what I noticed is that someone was going to work. They have to go to work. They would come home, a little bit of a cold illness. Maybe it felt like the flu. They would get better, but they would spread it. Half of the people in the family would get sick, and the elderly, before vaccine, would end up coming into the hospital having trouble breathing. And at that time, we were just in the dark trying to figure out how to handle the virus, how to deal with it, how to understand it, how to treat it. Then in the midst of the winter surge, when more than 3,000 people were dying a day, let me just state that again, 3,000 people were dying a day in this winter surge, vaccine got approved. And that was a godsend, because as you can see, a couple weeks after vaccine approval, right when you start building immunity, the virus numbers drop. So the new case reports drop like a rock. And then about that same time, what was going on in the world was virus was continuing to evolve. The UK had a strain, we call that the alpha strain, that evolved there. And then a little bit after that, a new strain evolved in India called the Delta strain. And India, as our numbers were going down, India was really struggling with being overwhelmed with this new surge. And then after vaccination, things looked really good in the US. We were talking about kids going back to school. And then we had this happen, our Delta surge. The Delta surge is a big deal. because with the Delta surge, we saw cases coming back to the hospital, but now they're different. In our hospital, 99% of the cases on the Delta surge are not vaccinated. These are unvaccinated people. So the Delta surge represents an unvaccinated population that's being exposed to a 4 times more contagious strain that also is more dangerous. And that's really a problem. I've actually seen only 1 case in our hospital that's come in fully vaccinated, needing oxygen, and that person did great, went home 2 days later. But the Delta surge is really a dangerous part of the pandemic. And this represents an unvaccinated group. What I also noticed in the Delta surge is that a virus comes into a family, someone gets mildly or moderately ill, but not half of the people get infected in the family, everyone gets infected. It's so much more contagious than the family with a shorter incubation period. Everyone gets infected, and then some people don't get better. In the early part of the winter surge, I would typically see more elderly folks come in with comorbidities and they wouldn't get better. It was really hard for them to survive. But if someone was 30 or 40 and they had moderately severe illness, they typically bounced back and got better in the winter surge. The Delta surge is not like that. If you're 30, if you're 40, if you're 50, even young people with or without comorbidities are getting very sick with the Delta surge. And we're seeing younger people die of the virus. So it's really dangerous right now to not be vaccinated during this Delta surge period. Here are the hotspots in the US as of October 5th. The purple areas and the dark purple represent the more activity in the United States. And you can see right now, Alaska is having a real trouble with that. I mean, Alaska is on fire figuratively and in real time with their struggle with forest fires. But you can see that the COVID activity in Alaska is horrible right now. Also parts of the US still in the West, the Northwest is struggling a little bit, but California seems to be doing okay. This is kind of broken down by age. These are new cases by age, as you can see. And I'll just point out here, this is in the winter surge. You know, we really worried about those over the age of 70 because they were coming into the hospital in high numbers and they were having trouble surviving. But we also saw in the winter surge, people over 60, between 60 and 70. We saw people between 50 in their 50s also coming in, but not as high numbers. And typically in the winter surge, these people bounce back. We saw a few cases of people under 40 coming in, and very rarely would we see someone under the age of 20 come into the hospital. We were seeing pediatric cases nationwide. Brazil had a real trouble with pediatric cases, probably because of the Delta variant at that time in Brazil. But now if you look to the right with the Delta surge, in the Delta surge, we still see those who are a little bit older coming into the hospital, and these are all unvaccinated. But notice in the Delta surge, between the ages of 30 to 60, we're seeing a remarkable bump in cases. And we're seeing more 30-year-olds come in the Delta surge than we are in the winter surge. And again, these are all unvaccinated folks. So to the right, the Delta surge is really a problem in all age groups, but a little bit more in the younger age group. So these are deaths. These are the reported deaths. And as you can see, the Delta surge to the very right, thank goodness it is starting to go down, but we're still seeing a number of deaths in the US. I'm going to point out something here. As of October 5th, we've had 43 million confirmed cases in the United States. We've had over 700,000 people die so far in the United States. For a US population of 330 million, we're seeing more than 1,800 deaths a day still in the United States. So the death rate in the United States is remarkably high. We're still having people die in Sonoma County of this virus. And now the death rate is in the unvaccinated folks. Again, here's that vaccine timeline where we saw a vaccine with a drop in the first surge. And if you don't get vaccinated, we're not going to see a drop in the second surge. Again, this is a very dangerous time to not be vaccinated because of this Delta variant. It's more contagious and it's more dangerous to all age groups. So this is kind of what happened in the center footprint. We follow our cases internally. And if you look to the very right in the Delta surge, we're not seeing that real drop off like we did in the winter. We're seeing this slow taper. And I think that's because people are back to work. Kids are back in school. You know, kids under the age of 12 can't be vaccinated, and they're going to pick up this virus in school. Not that many of those kids will become seriously ill, but they're going to spread it to other people who are going to be vulnerable, either either in their communities, in their classrooms, or even at home. So we're going to see a slow taper, a slow drop off of cases. And what I worry about is as a flu season kind of lingers on the horizon, and as the holidays are right ahead of us before the winter season, we may see more crowding of the population, and the unvaccinated cohort may again have another bump in numbers. So I don't think we're out of the woods yet. This is what's happening in Sonoma County. And if you look by age group right now, we're seeing that 20 to 50 is the largest age group that's getting positive tests and being hospitalized in Sonoma County. So again, we're seeing a younger cohort of people get infected, become ill, and if they're unvaccinated, end up in the hospital. It's really hard to see someone in their 30s and 40s struggling to breathe hour by hour, day by day in the hospital. So I'm going to give you some perspective. There's been a little bit of information about how this pandemic relates to the 1918 influenza pandemic. And there are some lessons learned here. First of all, I'll tell you that there were 3 waves in the 1918 flu pandemic. Again, that's influenza virus, not coronavirus, but there were 3 waves. And the second wave, which happened right in the wintertime, was a hammer, just like what happened with us. In these first 3 waves, more than 1 to 2% of the population died that year in the world. There were 50 million deaths in the world in the first year of it. But then what happened? Again, in 1918, they didn't have a vaccine back then for influenza. So the virus continued for 3 more years. So they dealt with a pandemic for 4 years, and they stacked up more and more cases. And if you, the first year after the vaccine was really, I'm sorry, the first year after the first wave was another hammer with the influenza pandemic. Now, this isn't the same time. Again, they were wearing masks, they were doing social distancing, but again, they didn't have a vaccine, they didn't have ventilators, they didn't have the care we have in our hospitals. Also, the 1918 was also World War I. Actually, this virus started in the US. It was called the Spanish flu, but it actually really started in the US. And we took this vaccine to Europe on military ships. So there was a tremendous amount of crowding in the military during World War I. In the United States at that time, there were 675,000 fatalities in the US. And at that time, our population was about 105 million. I'm going to compare that in just a million in a minute. So here's COVID. Here are COVID tests. And if you squash this, I'm going to compress this into a timeline here, and then let's compare it. So COVID pandemic to the left, the 1918 pandemic to the right, these look really similar. If we don't vaccinate more of the population, we're going to see this virus linger for a couple more years, and it could linger like a hammer. We may see a lot of more unintended and really tragic deaths happen without vaccinating our population. So again, let's compare these. These are 2 novel viruses. 1918 was a novel influenza virus. It's an RNA virus. And then COVID, also a single-stranded RNA virus. Now, what's really interesting is that COVID, coronaviruses are more contagious than flu viruses altogether. But flu viruses are typically a little bit more dangerous than coronaviruses because coronaviruses don't usually go into our lower respiratory tract. But with this virus, which we presume jumped the species barrier, does get into the lower respiratory tract and acts like an influenza virus. So we're going to look at a number of things. We're going to look at something called an R0 number, this R little o. This is a marker of contagiousness. The number represents how many vulnerable people will get infected from one person. So for measles, the most contagious virus we've seen, measles has an R0 number of 18. That means if one person with measles goes into a vulnerable, unvaccinated population, you can expect 18 more cases. So R0 is a marker of contagiousness. And then what do we know about mortality? Just because something's contagious doesn't mean it's severe. So we should keep that in mind. How severe is this COVID virus, and how does that compare to the flu? We're going to talk about worldwide fatalities based on population, as well as US fatalities. So in 1918, it had an R0 number of about 1.7, 1.8. But when you really crowded people in military cruise ships, in military barracks in 1918, then the R0 number, the contagiousness of the flu, got even worse. It had a mortality of 2.5. That's a big number. 2.5% of people got ill, they didn't survive. And oftentimes with influenza, this was the next day. It was oftentimes people died overnight. 50 million fatalities in the world back then, when we had a worldwide population of about 1.8 billion. There were 675 fatalities in the US, and at that time, our population was 105 million. So how does that stack up against coronaviruses? Well, I'm going to show you 3 different variants, right? The first variant that came out, the first evolution, which probably happened in Italy, was this D614G variant. And that had a contagiousness number of about 2.5. So one case, or 2 cases would result in 5 cases. As you know, Italy was really overwhelmed with that. The mortality of that was about 0.7%. The Alpha strain, which came out of the UK later, was twice as contagious. And then the Delta strain, which came out of India, was twice as contagious as the Alpha strain and 4 times more contagious than the original strain. The mortality, I think the Alpha and the Delta strain are a little bit more dangerous to younger populations, but overall the mortality is about 0.7%, so almost to 1%. We've had 4.5 million deaths worldwide, and we're not done yet. And this may be underreported, and for a population in the world of almost 8 billion people. So it still doesn't compare to what happened in 1918. But imagine if we were dealing with the influenza virus like they were dealing with back then. Now in the United States, we've actually surpassed the 1918 numbers. We've had 704,000 people in the United States die of COVID so far, and we're not done yet. But our population is 3 times higher than it was in 1918. So the prevalence of mortality is not as bad as influenza, but it's still, the numbers are staggering. How does that compare to seasonal flu? Seasonal flu has an R0 number about 1.2. So seasonal flu is not as contagious as the 1918 influenza, and clearly not nearly as contagious as the Delta strain that's circulating now, with a much lower mortality number. Every year in the US, 30 to 80,000 people die of influenza, and that pales compared to the 704,000 deaths from COVID-19 so far. So that's kind of looking at both of the viruses side by side. How do they stack up? And we're not done yet. I actually give this slide to the docs, just so you know that on the left-hand side, that's what we're doing right now. The blue treatments represent what we're doing in the hospital. The black treatments represent what's available in the outpatient setting, mainly monoclonal antibody or convalescent titer. On the very right, this is the stuff that doesn't work or it's dangerous. And so we're not recommending these as a national requirement. And then in the middle, what's in the pipeline. So it's a very, very dynamic process. But this is what happens when someone gets infected and we're struggling to keep them alive. We're struggling to treat them. We're struggling to help them just kind of get through this illness and do no harm. So this is the state of the union of treatment. Prevention is key, and the vaccine is the biggest saver of lives. So again, this is our testing positivity rate. And as you can see in Sonoma County, the Latino population has a higher average testing rate than any other ethnic group. Now, as you can see in the first part of the pandemic, when we didn't have vaccine, the Latino population was really struggling with infection because a lot of people needed to go back to work. A lot of people had to pay bills. And at the same time, in multi-generational families, everyone was getting infected with this. But now in the second wave, in the Latino population, we need to get more people vaccinated because they still represent the predominant number of people who still are getting infected and not surviving. So what are vaccines? This is what I tell patients. So let's just go back to basics. On the right is a cartoon of coronavirus. The coronavirus is sort of a circular virus. On the inside the envelope is the RNA material. On the outside are these purple spikes. They're really not purple, but the cartoon shows them. And if you look down here at the bottom, this is where the purple spike touches one of our cells and gets into our cells. So this is how it gets in, this is how it becomes infectious. So the coronavirus vaccines only look at the piece of the surface. They look at this little purple spike. This is a glycoprotein molecule that attaches to our cell. So the COVID vaccines are really focused on just making this protein spike. The vaccines don't make the whole virus. The vaccines are not live viruses. They're only making this purple piece at the very top. And what it was meant to do, if we just make this spike protein and we give our body a head start, our body can make protection or immunity against this glycoprotein spike so it won't attach to our cells. Like other viruses, like the flu vaccine, like other vaccines like tetanus viruses, pertussis vaccines, like other vaccines, this is injected into the arm like anything else. And they don't really hurt more than a tetanus shot. Tetanus shots hurt a lot. Tingle shots hurt a lot. For some people, the COVID feels about like that. It's not any worse than that. Now, a question I get a lot are, wow, we made these vaccines really quickly. Are they really that safe? We didn't make this vaccine very quickly. In the first SARS epidemic, which happened in 2003, countries, including the United States, very quickly got together and were working on this new vaccine platform. It took us 20 months to make this mRNA vaccine platform of the Pfizer and Moderna vaccines that we have now. But in that 20 months, SARS-CoV-1 burned out. And so we had no way of using it for disease. Now we had tested it in healthy populations. We knew it gave you a good immune response. We knew it was safe, but the SARS-CoV-1 cases were over, and there was no way to use it to prevent more illness. But it took 20 months to make it. The vaccine was put on the shelf, and then when this pandemic happened, we took that technology, we took that same vaccine, we inserted SARS-CoV-2, and that's how we have this vaccine. So we've had this technology for more than 15 years. This wasn't rushed, it was old technology, it was safe technology, and luckily for us, it was very effective. Because if we didn't have this platform of the Pfizer-Moderna mRNA platform, we wouldn't be in the place we are today. So what do vaccines do? They do a number of things. Really what they do is they boost your health. They boost your health by working with your immune system to better prepare us to fight off whatever the vaccine is meant to protect against. Whether it's a viral vaccine like this vaccine for COVID, we have bacterial vaccines, there's a new malaria vaccine out. We're trying to develop vaccines for fungus as well. So vaccines are meant to boost your health. If a vaccine makes you sore, I tell patients, whether it makes your arm sore, it gives you a fever, makes you feel achy, that's how you know it's working. It's working to stimulate your immune system. And you might feel that for a brief period of time after the vaccine. That's not a bad thing. We want vaccines to do 4 things in a perfect world. We want them to stop the spread of infection. So we want them to prevent infection, which prevents the spread. We also want them to prevent people from becoming ill. If you can prevent illness, people can stay at work and go back to school. We want to prevent them from people being hospitalized because that's where we're going to see a lot of mortality. So by preventing hospitalization, we can also prevent death from the infection. So vaccines are meant to do this. Now the COVID vaccines are very good, almost as good as the measles vaccine, clearly twice as good as influenza vaccines. The only thing that makes a difference in influenza is vaccination. The only way we save lives with influenza is vaccination. And clearly with a vaccine that's 2 to 3 times better than influenza vaccine, we're going to prevent hospitalization and death using the COVID vaccines. So these are the vaccines in the United States. Right now we have 3 vaccines. The Pfizer and the Moderna vaccine are probably the best and the safest vaccines in the world. So we are very fortunate to have the 2 best vaccines in the world in the United States. And the Johnson & Johnson vaccine, or the Janssen vaccine, is a very good vaccine. It's really good, but it's not as exceptional as the Pfizer and Moderna vaccine. Pfizer has been fully approved. In order to get fully approved status from the FDA, it's got to be safe and effective. The Moderna is right around the corner for getting that same approval. Johnson & Johnson is also approved under emergency use authorization. The Pfizer vaccine is good over the age of 12. The Moderna, the Johnson & Johnson, you have to be 18 or older for them. And hopefully the pediatric information is going out to the FDA soon. And we should have information hopefully by the end of this month. Pfizer and Moderna vaccines are 2 shots. The Johnson & Johnson is only 1 shot. And the Pfizer has been approved under emergency use authorization for boosters in certain populations, and I'll show you that in a minute. So again, the first thing that happens is vaccines go to the FDA. The FDA determines whether they're safe and whether they're effective. And right now, this month, the FDA is going to be meeting on the Moderna booster data on October 15th, the J&J booster data on the next day, October 15th. Also, they're going to be talking about mixing vaccines. Can you get a Pfizer and then a Moderna? Can you get a Moderna after a Johnson? The FDA is going to make a decision on that based on science, based on evidence of safety and efficacy on October 15th. And then childhood vaccines are going to be voted on the FDA, presented and voted on October 26th. Now, after the FDA makes a decision about vaccines, then the Center for Disease Control tells us in the public arena and in the healthcare arena, how do we use those vaccines? How do we position them? How do we situate them? What do you need to know about the vaccine? How do you store them? How do you transport them? So that'll be very important from the CDC. So again, the FDA approves them, and the CDC develops guidelines for how we should use them. So how well do these vaccines work? That's the most important question, and I get this question a lot. And I'm going to show you data from the CDC. So this isn't my information. This isn't my opinion. I'm going to show you data exactly that goes before the American Committee for Immunization Practices on the CDC. And this is their meeting that happened on September 22nd. This is new data from the CDC, and this is exactly what the CDC shows. How good is a Pfizer vaccine? Well, in the first 4 months after receiving the Pfizer vaccine and completing the series, it's 91% effective in preventing hospitalization. 91% effective in preventing hospitalization is an incredible number. We never thought the vaccine would be that effective, and that's a home run. Now, if you wait more than 4 months after vaccine, the Pfizer vaccine, it drops a little bit, which is why we're talking about boosters. What about the Moderna vaccine? The Moderna vaccine, 93% effective in preventing hospitalization, and it holds up after 4 months at 92%. The Johnson & Johnson, the Janssen vaccine, 68% effective. It's only 1-dose vaccine, 68% effective in preventing hospitalization. It's a good vaccine, but it's not as great as the Pfizer Moderna vaccine. So this is other data. What about the Delta strain? Again, we have this new, much more contagious and a little bit more virulent strain that's circulating. How are the vaccines stacking up against this? And again, we can talk about infection versus mild symptoms versus severe symptoms, hospitalization, and death. So if you get a Pfizer or Moderna vaccine, is it still possible to get an infection or an illness? It is still possible. So you can get a mild illness if you've been fully vaccinated against a Pfizer Moderna, but you're not going to get severely ill. And so yes, the vaccines are not perfect against mild illness or asymptomatic infection, but the real money here is they're going to save money. They're going to save lives, because in severe COVID disease, even with the Delta strain, the Pfizer still stacks up over 90%, and the Moderna at 96%. The J&J is still hanging in there, 85%. This is great information. And we need to tell our patients this, that the only way to meaningfully save a life is to get prevention with vaccination from 2 of the best vaccines in the world and clearly the safest. And now, are they safe? How do we know they're safe? We know they're safe because in studies, you had to look for any side effects, mild or severe. But actually, after the studies are done in maybe 30,000, 90,000 people, what happens when you put the vaccine in the community? We have this reporting structure. This is from the CDC called VAERS, Vaccine Adverse Events Reporting System. This reporting system is how we pick up really rare side effects that we wouldn't have seen in these large studies. From the VAERS, which has been around for decades, we've had this all the way back to the 70s. In the VAERS reporting, we know that about 60% of people get fatigue after they get the Moderna, the Pfizer, the Janssen vaccine. About half of the people get a headache. 38% of people get chills. Almost 40% of people feel kind of achy in the muscle, and 24% of people get achy in the joints, and those typically go away. About 16% of people get a fever. And then what we worry about is we picked up from the VAERS that a really rare side effect, which is inflammation around the heart, called pericarditis or myocarditis, happened in about 2 cases for every 100,000 doses. This is a rare side effect, but also what we found out in larger studies, that this is also a complication of the viral illness. And so if people get COVID illness, they get 4 times a higher rate of inflammation around or in the heart than they do from vaccine. So it's a rare side effect from vaccine, but it's more common in illness. So you're much more likely to get myocarditis or pericarditis from COVID illness than you are from the vaccine. Now, some people think, oh, it's better to get illness than it is to get the vaccine. In certain infections, that's true. But in COVID, we know that getting the natural infection only gives you about 30 to 40% protection. So natural infection is like 1 dose of Pfizer, 1 dose of Moderna. But the vaccine in this illness, the vaccine of this infection is even better than natural infection. And that's why people who get natural infection still need to get the virus. I'm sorry, people with natural infection still need to get vaccinated. Very important. So people that leave from the hospital, we want to vaccinate them within 30 days. So this is data on the boosters. After the third dose, as you can see, you still get fever, you still get fatigue, you still get headache, you still get chills, muscle pain and joint pain. But after the third dose, if you get the booster, it's not higher. So the vaccine response is better after the third dose, but the side effects are not as bad. The third dose is a little bit better than the second dose, but they're almost comparable. So if you felt a thumper on the second dose, you're going to feel a thumper on the third dose. And then here's what's happening with vaccination in our county. In Sonoma County, 65% of the Latino population has been vaccinated to both doses, 9.3%, 9% to 1. But 35% of the Latino population is not vaccinated. And that's higher than many of the other ethnic populations, except for multiracial and except for American Indian, Alaska Natives, which is a very small part of our population. The Latino population represents a large percentage of people that are not vaccinated. And I worry about this for two reasons. One, I don't want these people coming in the hospital and struggling to breathe and struggling to survive. Because the Delta variant is more contagious, we need probably more than 85% of the population to stop the spread of the pandemic. We call this herd immunity. Now, if we get vaccination, we don't just protect ourselves, we protect our families, we protect the elderly, and we protect others around us. So the best way to protect ourselves and one another is to get vaccinated. It's safe and it's effective. So how do I know it's safe? Because in the early part of the pandemic, this is my mom, you know, she was in Phoenix and they weren't organized enough to get vaccination. She was struggling with getting vaccinated. So I got in the car, I drove from Santa Rosa to Phoenix one day. I picked up my mom, I drove her back. And this is my mom coming into the Sonoma County Fairgrounds, getting her vaccination. And she was very happy to do so. This is her after her vaccination. She stayed with us. My mom is 89. She works in a free clinic. She's trying to help people who are underinsured and uninsured, especially in the Latino population. She actually is the director of Spanish interpreters in this Latino clinic in Phoenix, Arizona. And I didn't want her unprotected. And so she stayed with us for a month, got her second dose of the Pfizer vaccine, and then I drove her back to Phoenix. Now, again, do I believe in the vaccine? This is my son and I, the day we both got vaccinated. My son, Mateo, graduated from Rio Creo. He was going back to college. I didn't want him unprotected because he has asthma. So my son and I got vaccinated on the same day. And this is my daughter who's just starting college. My daughter's vaccinated as well because I don't want her getting ill in college. And I don't want her getting other people ill as well. So if you're willing to vaccinate your family, that is really evidence on how much I believe in vaccination. And again, what about boosters? The booster only pertains to the Pfizer vaccine, and certain age groups are recommended for the booster. People over 65 should get the booster, especially if they're living in long-term care facilities, because these are the people that lose their immunity over time. They lose their protection. People 50 to 64 years of age with underlying medical conditions should be vaccinated. And I'll show you the classifications or what are those medical conditions. People 18 to 49 with medical conditions, there should be shared decision-making with those patients because we don't want to see those patients have that pericarditis, myocarditis. And then people between over the age of 18 who are working in occupations like fire, police force, healthcare workers, and certain industries that put you more at risk, we're recommending a booster vaccine as well. I'm going to get my booster vaccine next week. These are the list of chronic medical conditions: cancer, kidney disease, lung disease, neurologic disease, including dementia, diabetes, whether it's type 1 or 2, heart conditions, HIV and immunosuppression, liver disease, not just obesity, but if you're just overweight, I'll raise my hand, I'm a little bit overweight. Pregnancy, this is a very, very safe vaccine in pregnancy. In fact, it's like the flu shot. You want to get a flu shot in pregnant if you're not already vaccinated. You want to get the COVID vaccine before or during pregnancy. It doesn't cause any adverse events in pregnancy. And there's also been some myths on social media about women becoming sterile or men becoming sterile after vaccination with COVID. That's completely unfounded, not true. So it's a very safe vaccine in pregnancy. It does not affect fertility at all. If you have sickle cell disease, if you're a smoker, if you've had a stroke, if you have issues with substance use, alcohol, marijuana, other drugs, again, those would fall into conditions where you get a booster vaccine. And again, this is a patient who is struggling to breathe in our ICU. And again, COVID illness is a preventable disease. We're so fortunate to have the two best vaccines in the world that are remarkably safe. And I cannot tell you how dangerous of a time it is not to be vaccinated right now with the Delta strain, especially as we go into the winter with the holiday season, more people traveling, more crowding in cold weather, and more families mixing. It's a very, very dangerous time not to be vaccinated. So I hope that helps. And I'm gonna see if you have any more questions. And I'm gonna hand this back to my colleagues in the forum. Thank you very much.
Thank you so much, Dr. Green, for your informative presentation. We do have some questions. So I'm going to start off with some questions to get answered about specifically about the vaccine too. Does a person who is fully vaccinated, are they required to get a booster? Can you talk a little bit about the eligibility booster?
Yeah, that's a really good question. Yeah, no, boosters are not required. They're just recommended. So, you know, people make a choice about getting the flu shot. People are going to make a choice about getting a booster. I'll tell you what I'm not seeing right now. I'm not seeing vaccinated people coming into the hospital with illness. But I think, and that's it, probably what we're sitting in about 10 months after people got their very initial first shot in January. But we don't know what's going to happen with waning immunity. Will you lose more of your protection as the year goes on? And what if we see a new strain? So getting a booster now is really protecting yourself if things change in the pandemic in the winter season with a new variant or with weakening of your immune system. So I think it's protection moving forward, but no, it's not mandated.
Perfect. And then another question that we have is what's the best way to protect children that are unable to get vaccinated and are back in school until a vaccine is approved for the younger ages of 5 to 11 years old?
Right, so we expect vaccine to be available by the end of the month. So the FDA and the CDC are going to come down really quickly on this decision. We know that already preliminary, the vaccine is very safe. Just so people know, the pediatric Pfizer vaccine is only 1/3 the dose. So it's not full strength. We're giving 1/3 the dose to kids. The vaccine data looks really good. And I think what's going to be very important, not only just for kids, but for kids protecting the rest of the population, is I think vaccine will be available by the end of the month. Now, I know the Public Health Department and other consortiums, other medical groups are already working together to say, how do we get ready to start vaccinating kids? So operationally, we're preparing the vaccinated kids so it's not the confusion or the chaos that we saw in the early part when we had the tiered groups for who gets vaccinated, who's not vaccinated. So I suspect vaccinating will start probably late October, early November. And I think that's going to be the real season where we're going to just in time have the protection before Thanksgiving and Christmas.
Do you anticipate seeing a similar tiered system for children, like wanting to vaccinate children that are at a higher risk in any way, or do we expect it to be a little bit more of a general?
I think it's going to be wide open. It's going to be wide open for kids. And I think we're going to make it as easy as possible. And again, the vaccine is free. So, yeah. I mean, it's incredible not to take advantage of this.
Yeah. You know, and a lot of the community outreach work that I do on behalf of Sutter to help increase the number of folks getting vaccinated. We often hear the question of, can I get my COVID vaccine, COVID-19 vaccine if I have an underlying condition? Like, people are hesitant to get vaccinated because they have diabetes or because they have high blood pressure. And there's this hesitancy or this fear that a vaccine or the possible side effects will only increase the complications of their chronic disease. So what would you say to a person?
Yeah, so people with chronic conditions are at higher risk of not surviving the illness. And the vaccine doesn't really impact their chronic conditions. So I would say if someone, for example, is going through cancer chemotherapy, the vaccine is very safe for them. But because of the chemotherapy, they may not respond to the vaccine. And so they still need to be very careful. But if someone has heart disease or lung disease or diabetes, the vaccine's not going to make those diseases worse, but those diseases will make it harder to survive the virus. So the vaccine is really safe. Remember, it's not a live attenuated vaccine. It's not a live vaccine. It's only a piece of the surface of the virus. And so it's a very safe vaccine. And so it won't make the disease worse, but their disease will make it harder to survive without the virus. So those with medical conditions are the ones we really need to reach out to the most, because those are the ones who are not going to survive.
Thank you. And then another question that was asked is that ideally if a person has had both doses of Moderna or Pfizer or the one dose of J&J, is a person fully protected? Because somebody has shared that they received their J&J vaccine and 20 days later they contracted COVID and had all of the COVID symptoms.
Yeah, so some people, I mean, if you've been fully vaccinated and you receive enough of an exposure to someone, you might get a mild illness. But so far it's asymptomatic or it's super mild. And you also may give it to someone else when you have mild symptoms. But the period of infectivity is much briefer. It might be 1, 2, 3 days for people who are vaccinated and they get a mild illness, where it's going to be, 9 to 10 days in someone who's not vaccinated. So if you get vaccination, you still want to be careful with masking. You still want to be careful with hand washing, and you want to be careful with not mixing with people who are unvaccinated, because you still might get a mild illness, but your chance of being hospitalized, your chance of not surviving are just about negligible, clearly less than a fraction of a percent.
Wonderful. Another question too is if public health will hand this over to pediatricians, or will the vaccine be allocated by public health departments as it was for adults initially?
So we're hoping all of the above. We're hoping to get vaccine with the public health department. We're hoping to get vaccine in pharmacies like CVS and Walgreens and Costco, and in doctors' offices. The other thing I didn't present is that you can get the vaccine with other vaccines as well. So you can get a flu shot and a COVID booster at the same time. So early on, we didn't know how to stage the vaccines with other vaccines. And now we know, having a year more of data with vaccination, it's safe to get this vaccine with other vaccines as well. So we're hoping that when you go to Costco, you go to CVS, you go to your doctor's office, once you get flu shot, you can get your COVID shot at the same time.
Thank you. And another question that we have is, as an outpatient primary care clinician, other than vaccination, we do not have any options for the management of COVID-19 illness or prevention. Can you speak to why outpatient management has been so limited?
Yeah, so we're learning about the virus as we go, and we know that in mild illness, we don't know who's going to get worse, who's going to get better, but those with chronic conditions are more at risk of getting worse. And so what we've learned is that in the outpatient setting, monoclonal antibody or convalescent plasma, if the convalescent plasma has high enough protective titers, those are helpful. So we do have outpatient treatment, and the outpatient treatment for prevention and the outpatient treatment for treatment would be monoclonal antibody like Regeneron or convalescent plasma. And actually Sutter Santa Rosa was part of the Mayo Clinic study giving convalescent plasma. And that was really important to us. The other thing that works in the outpatient setting is your diabetes control. We know now that patients who have tighter and better diabetes control survive the virus better. And so we encourage our primary care docs and our teams, our endocrinologists, the better people are controlled for their diabetes, the better they are to survive COVID illness. So we encourage people, don't go off your high blood pressure meds, don't go off your cardiac meds, don't go off your diabetes treatment. Now, when you get ill and you're in the hospital, then we have a number of treatments that we use. We attack the virus in many ways, but we know that those treatments in the outpatient setting don't make a difference. So we know that what you do to stop the virus in severe illness is different than how you stop the virus in mild illness. And so our treatment regimens are very different in the hospital versus in the outpatient clinic. So now in the hospital, we don't give Regeneron. We save that for outpatient use because it's better used in the outpatient setting.
Thank you. And then an additional question we have is, how long after getting fully vaccinated is a booster recommended?
You want to get the booster after 5 months of your full vaccination. So you really want to wait the 5 months, and that's going to be like the sweet spot for getting your booster. After, in that 1 to 5 month period, you're not more at risk because you still have a lot of immunity. and again, we're not seeing that in the hospital. We're not seeing vaccinated people get hospitalized, and it's been 10 months since their initial series.
And then another question that we have is, do you foresee more hesitance with people that are fully vaccinated towards the booster?
No, people who have been vaccinated, they want the booster. So, and in the unvaccinated camp, I see two people. There are people who just have this ideology, this belief system, and they believe in conspiracy, and it's a belief system for them not to get vaccinated, not just against COVID, but about other things as well. And then I also see this cohort of people who just need more information. They need more dialogue, more conversation. And I think in the Latino population, for example, I think we just need more education, more information, and we need to answer more questions so that people can make that decision that's good for themselves. But I do see a cohort of folks, and oftentimes they're not Latino, that are just dug in deep, and they see this as an assault on their personal independence and their personal rights. Now, we're a country where independence and our individual rights is very important, and I think we should preserve that, but not at the expense of putting people's own health at risk and others at risk. So when you have somebody that's really safe and really effective, for example, like a seatbelt, we want to use seatbelts when we drive down the highway. We want to wear a helmet when you're on a motorcycle or a bike, or a skateboard. And that's the same way with this vaccine. We want to be safe. We don't want to recommend something that's not effective and not safe. And we're very fortunate to have this with the vaccine. So for those choosing not to be vaccinated, they put themselves at tremendous risk. I often tell it's like saying, well, I want to drive down the left-hand side of the road, not the right-hand side of the road. That's pretty dangerous. And being unvaccinated is like that right now.
And then you don't have to answer this right now, might be something that you'd be able to share by email. Is there a specific resource that you would recommend that we can share that lists vaccine information and possible side effects that would be easy to distribute?
Yeah, that ACIP presentation is actually available online. If you go to the CDC website, cdc.gov, you can see all of those slides and all of the data that the ACIP vote on. And you can actually attend those meetings. You can stream those meetings live. You can see how the FDA and the CDC is voting. But that presentation is available online. And I would be happy to forward the whole thing to you, and you could put it on a social media site.
Thank you. And then I know this question would actually probably be to multiple different stakeholders, but do we have data from the Native American population in Sonoma County that's been fully vaccinated?
I'm sorry, say that question again.
If we have data from about the Native American population in Sonoma County that have been fully vaccinated.
Yeah, actually, we do have that information. Our Sonoma County epidemiologists have broken that down as carefully and detailed as they can by ethnic groups. And certainly we can get that for everyone if they need that.
Thank you. I did have one question that was related, going back to what we talked about as a fully vaccinated person and the time frame that they feel complications if they do contract the virus versus a non-vaccinated person. But how does that compare ideally to a person that chooses to get vaccinated and the possible side effects? Because you did list them out by kind of the frequency and percentage of frequency that they feel, but I think there's often that we see hesitancy that folks are fearful of getting vaccinated because they might miss work, or they have they can't afford the downtime, they have that economic instability and want to continue to be able to work and provide for their family.
Yeah, I would say that if you've had a tetanus shot, or you've had the Shingrix, the shingles vaccine, it hurts about as much as that. And you can feel kind of crummy for a couple of days, but it's pretty uncommon for someone not to go to work. In fact, we have that data from the health department and from the CDC. It shows that it's less than 15% of people who have any side effects. It's so bad they can't go to work for one day. But what I tell patients that are worried about missing work because of the vaccine, I'm like, imagine how much you're going to miss work if you're hospitalized. It's really like Russian roulette. In the early part of the pandemic, the virus was not as contagious, it's not as dangerous. Now that it's 4 times more contagious and more dangerous, to younger populations. I really worried about take the risk on being achy for a couple days because the vaccine's working. When you feel kind of crummy, it's working. And maybe get the vaccine on a Friday. Get the vaccine on a Friday so you have Saturday and Sunday to recover from it. But the downside of that is being hospitalized. When people are hospitalized and survive this, the average hospitalization is 3 to 5 weeks. People are on a ventilator for 2 to 4 weeks when it comes to that. So I just can't impress enough, how dangerous it is.
Absolutely. And I know that you did mention this earlier, but just so that we can reiterate this for our folks, is that boosters will be free of charge for those that are not insured.
That's correct. That's for everyone. Insured or uninsured, they're free of charge. Right. So the government has already paid for boosters, so it's really not free. It's your tax dollars.
And just some kudos that are coming in through the chat. An excellent presentation, very clear, science-based. Thank you so much. I am going to, I believe we don't have any more questions.
Are there any questions from Enrique?
Uh-oh, Dr. Gonzalez, you're on mute.
Oh. No, I'm okay. Oh, still. Oh.
We can hear you.
Yeah, well, thank you very much, Dr. Bean. No, I read a couple places that there's some children that develop inflammation in the heart with the vaccine, and people are very concerned about it. What I read is the numbers are so low. What is your experience with this?
So, because we're not vaccinating kids yet, we have to go to the studies. What do the studies show in vaccine? And also we have a lot of data from Israel because Israel rolled the vaccine out to the entire country. The data from Israel and the data from the studies show that that myocarditis or pericarditis is the most common in teenage and young men. We don't know why. So this is all comers, right? So any kid that gets myocarditis or pericarditis, the boys are more common than girls, and it happens in this teenage 20-year-old population. So, and that usually happens from a lot of viruses: flu virus, enterovirus, adenovirus, rhinovirus, and sometimes just autoimmune. So that's kind of the population that seems to get pericarditis the most in the general population. Then with COVID, we're seeing that in all comers. We saw it early on. We saw, heart disease early on in the elderly in the first part of the pandemic. And now we're seeing it a little bit more in people who are younger. And I've seen people in the ages of 40 not survive that from COVID illness. So when you give the vaccine, there's a slightly bump in those cases in people in this teenage 20-year-old age range, like maybe 18 to 30 age range, just like there would be in the normal population. But what we're noticing is it's about, if you give the Pfizer vaccine, you can expect about 2 cases of very mild pericarditis, myocarditis in every 100,000 doses. But in the boys and young men from maybe 15 to 30, it's about 16 cases for every 100,000 people. So it's still very low numbers. I think that's rare, but it's not zero. So when my son and my daughter, who were 18 and 21, got the vaccine, I didn't even think twice about it. It was so rare, they had a better chance of winning the lottery. So I didn't even ask them, do you have chest pain? Does your heart hurt? They just got the vaccine. My son's arm was kind of sore, and he was kind of complaining that he couldn't work out. My daughter was a bit of a trooper. I think girls are tougher than boys, so my daughter just slugged through it. So yeah, I would say it's around 2 to 10 events for every 100,000, and half of those cases are very mild, and they get better on their own in a day or two.
Yes, Dr. Wu. I wonder if you'd be so kind and reassure our Latino population, because one reason that people are saying they don't want to get the vaccine is because it might cause infertility. And I've been saying, I don't see how. But from an infectious disease consultant, a specialist, maybe will be more effective. So,
Yes. So I'll
yeah.
tell you that any vaccine, pregnancy is looked at very, very carefully. And so when these vaccines were being developed, first thing we looked at was any trouble with pregnancy. The most cautious thing we do with vaccines is pregnancy. And so very early on, we were looking carefully at one, does the mother put herself at risk? Does she put the baby at risk? Does a mother get immunity? Does a baby get immunity? And so very early on, we knew that there was no signal. Now, in the early studies, pregnant women were not included in the very early studies, but some of them got pregnant anyway during the study, and all of them did fine. There were no adverse events. Now we have the VAERS data. We have millions and millions and millions of pregnant mothers getting vaccinated, and there's no adverse outcomes. I'll tell you on the downside what I've seen is I've seen pregnant women unvaccinated get COVID illness. I've seen them struggle to breathe, struggle to save the baby. And in a couple patients, we've had to send them out to San Francisco to an intensive care unit. So we know that COVID illness is much more dangerous in pregnancy than non-pregnancy. But COVID vaccine is just as safe in pregnancy as the flu virus is. So there's no downside to being vaccinated in pregnancy. It puts absolutely zero risk of the mother or the baby, and it has zero implications for fertility. The difference in today's world is that everyone has social media. And there's so much misinformation in social media that people have trouble understanding, is that true? Is that not true? Just because someone says it and they say it clearly, does that mean it's right? And I really like, for example, YouTube is starting to take down information that is erroneous and wrong. So hopefully our social media platform will get better. But I tell my mom, don't get on Facebook, don't get on Instagram, because there's so much misinformation there. If you want information, go to a place like the CDC. Sonoma County Public Health website is good. The NIH, the National Institutes of Health, incredible information. Johns Hopkins, the Mayo Clinic, these are places where you can get good information that's reliable and credible. But unfortunately, a lot of information and misinformation has even happened from medical providers. And we know now that the California Medical Board and certain places like the American Board of Internal Medicine, they're going to be sanctioning physicians for purposely putting out misinformation about vaccination or false treatments. So that's going to be really important as well. But very safe in pregnancy, no fertility issues. If my daughter was pregnant right now, I'd make sure she'd get vaccinated.
Yes, thank you, Dr. Green. In fact, I read also that medications like ivermectin can cause some reduction in the number of the sperm and some problems in the fertility of males. So this misinformation that we're calling now the virus of misinformation is even more dangerous than the COVID in some cases, because people believe, as you said, and there's no sanctions. Doesn't seem to be an ethical morale to say don't misinform.
Yeah, I think what's really important is that as a healthcare provider, whether you're a social worker, physical therapist, a nurse, a doctor, we really need to reach out to our neighbors and our patients in the community and just build trust. You know, people are frightened, people are tired, people are exhausted, people are struggling to keep their mortgage and their jobs, and people don't want to go to work and then get exposed to someone else. So this is a really, really tough time in our history. And I think as a healthcare worker, even though we're all tired, it's important to build those bridges in the community and to reestablish trust. And some people are going to believe you, some people are not, but earnestly, we need to keep being honest, keep being evidence-based, and keep using science to make good decisions. We need to keep medicine out of politics. We need to keep medicine out of social media so that we can just take care of patients.
Yes, thank you very much, Dr. Green. No more questions that we know, Andrea?
We have just one more. I think it was, again, just a little bit more affirmation too, because this is actually another common one that we see within the Latinx population as well, is that I've already gotten COVID. Why should I still get vaccinated? I already have protection against the virus with the antibodies that I've built.
Yeah, so with some illnesses, getting infection is better than getting the vaccine, but with COVID, we don't understand why this is scientifically. So we're trying to figure this out from an immunology standpoint. But getting illness only partially protects you. And that's why early on in the pandemic, we saw people get reinfected and then they would come in and get really sick again. And so we know now that with natural COVID illness, whether it's mild or hospitalized, that's only like getting one of the doses of the Pfizer Moderna vaccine. You have some immunity, but not great immunity. So if you really want to prevent reinfection that results in being hospitalized, it takes the full series of the vaccine. So luckily, in the era of smallpox, we were giving a different, this is in the 1800s, we were giving a different vaccine and some people had bad reactions from it. And the smallpox vaccine today, if you need to get it, if we ever saw an outbreak for biologic warfare, it would still have vaccine issues, and some people couldn't get it, including pregnant, including people with asthma. But this vaccine, we're so fortunate to have a safe and effective vaccine. And I think what's going to happen in time, we're going to look back, and hindsight's 2020, we're going to look back and say, what were we thinking? That was such a good step. And in the United States, we have the best two vaccines, safest vaccines in the world. I actually feel badly for other countries that are struggling, other third world countries, especially Latin America, Costa Rica, Nicaragua, Brazil had a horrible time with COVID because they didn't have enough vaccine and the vaccine they had was not as good as what we had. So I think we need to take advantage of what we have now and then also share it with the rest of the world.
Absolutely. There is one more question that we had. It was more specific to testing. Is that should families that have children under 2 years old get them tested?
Say that again?
If families have children under the age of 2 years old, should they also be tested?
Should the children be tested? If they're symptomatic. So any kid with like a cold, with cold symptoms, fever symptoms, myalgias, and even little infants, if they're sick with an illness, they should be tested because it might not be COVID, it might be the flu, and then if it is a flu, we have antiviral medication to treat them for the flu, so yes, they should be tested. And also one question I get a lot is, should I get an antibody test before I get vaccinated? And it doesn't really matter because even if you have antibody testing, we don't know if those antibodies are protective. So antibody testing doesn't mean you do or don't need vaccine. You just don't even worry about it. Get the vaccine. If you have been vaccinated, vaccinate now. But I really think not having vaccination is like driving down the 101 without a seatbelt, without an airbag at 100 miles an hour.
Absolutely. And you touched on this topic a little bit earlier around providers that have patients of pregnant women and their advisement of getting the vaccine or not, but we have a little bit more of a general question around that. Is that, some clients in the community state that their medical providers have advised against the vaccination. Is there any kind of clinical education or guidance for medical providers? And this has actually been seen, I guess, particularly more in Central Valley and other conservative areas.
Yeah, so early on when vaccine was developed, we didn't know about the pregnancy element of it. We were still studying that. Now we know that. So this is the time when I think when public health departments can issue more updated information to providers, but I'll tell you, some providers are also digging in. So I think that providers that are not pro-vaccine, especially in a safe way, maybe should not be practicing medicine during this pandemic.
Well, I think that was the last of all the questions that we had. We had quite a few, so thank you for taking the time to answer all of them. I wanted to be able to thank you for all of your time and attention towards your presentation, and thank our attendees, of course, for joining us today. And I wanted to also give a friendly reminder to everyone that we will not be having a workshop on Monday, October 11th in observance of Indigenous Peoples Day, but we will resume workshops on Tuesday, October 12th. Our workshop that day will be titled Working Together During and Beyond COVID-19. This workshop will focus on fires, floods, and now the global pandemic our community has been able to come together and respond to time and time again. So each time individuals from all different backgrounds come together to respond to the needs of community and help navigate and access services and advocate for how we can improve as a county to be better prepared and support those who are most impacted. So we are fortunate enough that we'll be able to hear through a presentation from those that would like to share the impact and amplify the work in our community based on the promotoras, promotores, and youth promotores, and have had in a COVID response to support our community. And in addition, we'll be able to explore the collective impact and response that many community-based organizations have had to address vaccine equity and beyond. So we're excited to be able to hear from a group of well-experienced folks in this arena, from Carissa Moreno with Center for Wellbeing, Guadalupe Navarro and Stephanie Maneri from Latino Service Providers, and Javi Cabrera Rosales from La Plaza, and our Doctora Jenny Fish, who is the co-founder of HP. So again, I thank everyone for being able to join us today for this informative workshop, and we look forward to seeing you again on Tuesday, October 12th.
Thank you very much.
Dr. Gonzalez, you're on mute.